on our own Vasa Previa. We'll focus both on the diagnosis side as well as some innovative therapy that we have been doing here at UT Houston. Could be an option for some of your patients. Challenges around that and how it makes an impact on the clinical outcomes. So when you talk about Vasa Previa, first thing that come in mind is admit to the hospital, do a C-section. That's been drilled into our minds right from our residency time. The anxiety around the vessel rupture and the catastrophic outcome that can happen with it is pretty evident for patients moment to talk about it. The anxiety that goes through with it, and it's pretty obvious. So this innovation hopefully will change that perspective on some of these patients. So we'll go through this. No conflict to disclose regarding this topic. So we're going to address some of the types of Vasa Previa and how to improve the diagnosis using screening. You may be doing a one method, but we will talk about how we do it at UT Houston, developed over a period of 10 years. It has made a big difference in our patient diagnosis as well as some of the clinical outcomes. And then what's the rationale for doing a laser surgery type 3, and then some details of the procedure so that you kind of understand how we do this and then outcomes because of it. So there's type 1 Vasa Previa. This is a cord insertion right over the internal os. That's a simple way to think about it. The cord is right over the internal os. Now, more often than not, if you miss this diagnosis, you will have a variable disease of the stage 1, or you do a vaginal exam and actually feel the cord right there. And that's how we clinically get diagnosed. And these make up at least literature says 70%. In fact, I think it's less than that. It's probably around 40-50% are type 1 Vasa Previa, but all the others are type 2, type 3, because more often type 3 are missed in the diagnosis. So type 2 or type 3 is everything else is, type 2, type 3. Type 2 is simple way to think about it is if there's a subcentrate lobe somewhere else and a main placenta somewhere else, and there's a connecting vessel that goes over the cervix. That's type 2. And type 3 is there is no subcentrate lobe. The vessel is traveling from main placenta to the main placenta somewhere else. It's just taking a detour outside of the placenta and runs over the cervix. So that's the type 2, type 3. And for a laser consideration, it has to be a type 2 or type 3. Within that, we have some nuances as how to decide who may be, who may not be procedure. We'll talk about that. Now, this is for residents and sonographers and fellows. Now, who should you screen for a Vasa Previa? What we know is the biggest risk factor for Vasa Previa is cord insertion in the lower uterine segment, which is type 1, could be a type 2, because the cord could still be in the lower uterine segment, not from over the cervix, but it could have a vessel traveling over the cervix. And then we have velamentous cord insertion. Of course, there is a cord prolapse in a labor. It's more likely a Vasa Previa because the cord is not able to get away from the lower uterine segment or in front of the head. Abnormal placental forms and placenta previa, low-lying placenta that is dissolving, fetal growth restriction. So if you look at those as the risk factors, you can see how the factorial risk factor is 1,000-fold for the top one, and bottom is around 10%, tenfold. However, in our UT center, almost like 12 years now, we have adapted to universal cervical length screening, mainly for enrolling into the prospect study. While we started doing that, we adapted to the universal Vasa Previa screening. And I'm going to go into some of those details. Now, that has made a big difference. In the number of cases we diagnosed almost doubled ever since we moved into a universal cervical length along with the Vasa Previa screening. So we all have a very clear understanding about what is the implication of prenatal diagnosis versus postnatal diagnosis of Vasa Previa from mortality, perinatal mortality, or is significantly higher with not having diagnosed prenatally. But it's not 100% mortality. So 50% means there are some of those vessels can be there, may not cause problem, but still a pretty high percentage can have a neonatal death. Of course, once you're diagnosed, they end up having a C-section for sure. And you can see here, some of them did deliver vaginally. Of course, the mortality goes up if you have a vaginal delivery. Now, one of the thought process is you could have a Vasa Previa that you did not diagnose. They go into labor. In the labor, they have a bleeding, and then the heart rate goes down, and you do a C-section, and baby comes out as anemic, and then we call it an abruption. But in fact, it was a Vasa Previa that ruptured. We never really uh, picked up before surgery. So these are the things that happen. In fact, it was a habit for us, that was built into our brain, that when you have a vaginal birth or a C-section, always examine the placenta, look at the cartilage, and look at the fetal surface, and see all the vessels are intact, and see what is going out and what is ruptured. So that was like kind of really, really drilled into us. And in fact, even now when I walk into the labor and delivery, at some point I talk to the residents, and it usually goes into the bucket and down into the pathology. No, you have to take a look at it. You gotta have to learn what it looked like at birth. So SMFM recommendation is, you have a risk factors, you do a transvaginal ultrasound, and if the Vasa Previa is less than 2 centimeters from the internal os, and then you repeat the ultrasound 28, 32 weeks, and then you do cervical length assessment to kind of monitor whether outpatient or inpatient. If it's more than 2.5, consider over 35, 36 weeks. If less than 25, consider hospitalization and steroids. And of course, if it's really low, like less than 10 or 15 millimeters, then you kind of move towards the delivery sooner. So if his fetus is viable. That's the process we also follow in terms of how, when we admit them to the hospital, how we manage them. But the Vasa Previa distance from the internal os, that is an evolving situation. Less than 2 centimeters has always been historically considered, probably came from the placenta previa, low-lying placenta, but we have expanded that to 3 centimeter, then the 4 centimeter. Currently, we are almost up to the 5 centimeter in terms of what we call as Vasa Previa, because of some anecdotal cases that we had, was 4 or 5 centimeter, went into labor, baby bled out in labor and died. This was almost 12 years ago. And these type of reports are popping up again and again, anecdotal reports. So we do talk Vasa Previa, anything less than 3 centimeter, but between 3 to 5 centimeter, we do talk about it as a discussion with the patient, and then make a shared decision making about what they want to do. So I want to make sure you really have a good understanding. Now, question is, how do you diagnose a Vasa Previa that is not over the internal os, that is far away from the internal os? How do you diagnose it if it is actually on the lateral side, not on the midline, it's actually the lateral? How do you really diagnose the distance from the internal os? I'm going to go through some of the things that we developed over time. So first and foremost, you have a high degree of suspicion for every patient. And I call it, the way I teach our residents and fellows is always, once they're pregnant, doing a transvaginal ultrasound, always think there is a Vasa Previa. You have to prove yourself that there's no Vasa Previa. That's the way to think about this. That's the only way you can actually pick this up, because you're trying to see something that sometimes may not there. And that's the challenge about, the diagnosis of Vasa Previa. And we do this on transvaginal ultrasound, bladder empty, you do cervical length measurement, then you do a color Doppler sweep from side to side. What do you mean side to side? Sometimes it happens that they have a vaginal probe, and then you do side to side, means you start to like move the probe side to side, but your tip is still at the internal os. So the good way to do this is to get the tip to the broad ligament on one side, and then move it to the other broad ligament. You can pick up a pattern, left to right or right to left, pick one. And that way you can always know it's going from side to side, and you do a very slow movement of the probe from side to side, and you keep the color flow, PRF, of the flow around 9 centimeter. The reason for that is fetal veins flow rate is around 10 to 12 centimeters per second, whereas the arteries flow at around 25, 30 centimeters per second. So if there is a fetal vein, and if your PRF is very high, you're not going to see it. May look like a little cheerio on the membrane, but to see the color in the vessel, you have to bring down the PRF. And to avoid artifacts of the fluid movement, if the baby's head is cushioning in and out of the cervix, it's going to create a false signal of Vasa Previa. You just have to wait the fetus stop moving, or you can even hold with your one hand suprapubic. Just hold the head in a stable position, and that will allow you to make sure you have less artifacts when you're doing a Vasa Previa screening. And then you measure the distance of the vessel from the internal os. For a vessel that is on the lateral surface, not in the midline, you can do something called omni-view. You do a 3D volume of that, and then do an omni-view, and then you can trace it from the internal os to the lateral distance. I don't have a clip of how to do that. This is something that we will, create one and happy to send it over to you. But it's not too terribly difficult, and you could even do a rendering and then switch it over, slice this laterally, and then measure the closest distance possible. And if it is suspicious, you remeasure at 28 to 30 weeks, because 1/3 of the time, the Vasa previas disappear or they migrate away. The way I explain to my patients is a vessel that is over the internal os at 20 weeks is not going to go away, because it's right in the middle, right on the smart at the top of the cervix. And as the cervix starts to efface, it tends to stay right in the middle. But if it is slightly further away, like 3 centimeter at 20 weeks, it's going to go away by 28 weeks. But 2 centimeter could become 4 centimeter. 1 centimeter could become 2 centimeters. So the farther it is, the moves away much easily than that is more closer to the midline. So I have some clips here. It's a real cases, and I want to make sure, kind of follow me along, as what I'm showing. Here is a transvaginal ultrasound of a patient, and here is at less than 10 centimeter PRF, and you can see internal os comes into the view. This clip is quite fast, and you want to be a little bit slower than that. And you can see the internal os right there, and over that is a bright flowing vessel, and you do a pulse wave on it, and it's got a nice fetal heart rate. These are one of the most commonly detected Vasa previas, and they are the most easiest one because they pop in front of your face, because they light up because there's such a high flow. So now here is another patient that has a sweep, and you can see a little Cheerio that is going side to side. And when you put a pulse wave on it, it has a low flow. This is a venous flow. That's why you want to really bring down your PRF down to around less than 10 centimeter. And if the vessel is going side to side, like here, doesn't really light up because the vessel is horizontal, perpendicular to the ultrasound beam, or the Doppler effect, it doesn't light up. So you have to kind of do a sweep side to side when the vessel becomes a little bit more angle on it, and it'll light up on the ultrasound. Another important aspect of the fetal versus maternal. This is another thing that keeps coming up. Fetal vessels always bulge into the amniotic cavity, whereas maternal veins are deep in the maternal stroma, and they go into the broad ligament. The fetal vessels, you can trace them onto the placental surface. Very important. The difference between a maternal vein versus fetal vein, and the fetal veins are always a little harder to detect on ultrasound. Now, here is a case. I want you all to kind of pay attention and see whether you pick anything up here. So this is the patient that was 21 weeks, had an ultrasound, had no concerns about Vasa Previa, and went home. And then she comes back at 28 weeks because there was a growth restriction, and we did transvaginal ultrasound, and then found this vessel. Now, take a look at the difference. This is the same patient at 21 weeks, was not called as a Vasa Previa. But if you slow it down, you can actually see a flash of color come in between that, if your eyes pay attention to it, right there. But you could have really called this some kind of fluid artifact and walk away. But you can actually see a little bulge that you see on the membrane. The reason why it was not picked up is because the PRF was kept very high, 35 centimeters per second. So you didn't have a sensitivity in the Doppler to pick up a vessel. So you really want to pay attention to the PRF when you're doing a transvaginal ultrasound to kind of really bring it down so that you can really see the vessel light up, and then you put a pulse wave on it. So those are the key things. Slow down, do a sweep to side, and then know whether you're looking at an artery or a vein, and then the pulse wave forms during that time. And here is another patient, 29 weeks, and she also had a couple of scans before that, was not diagnosed at all. I want you all to see if anybody can pick up what you're saying. Since it's WebEx, this is where I love interactive talks, but and it gets a little challenging to do this on a virtual. This is cervical canal, and that's the anterior lip of the cervix. You can see the placenta right there, and this is, I'm sure you can see the pulsing vessel here. That's a fetal artery that we all know it may be marginal vessel. And right underneath here is the maternal sinus that is flowing into the maternal stroma. I'm not sure how many have picked up a little Cheerio right there. Okay, that is a vessel that is bulging into the amniotic cavity outside the placental territory over the internal os. And same patient, you slow down and then follow side to side sweeps. You can see that vessel is actually outside the placental surface and flowing as a vasa previa. So you have a marginal placenta previa with a velamentous vessel running on the edge of the placenta, and I also have a vasa previa sitting over the internal os. It can be that simple, or that can be that, if something else is distracting your eyes, you didn't pick up a vasa previa sitting over the internal os. How would you manage differently? One would try to labor this patient because of marginal previa, or you would do a C-section, not be in the hospital. She could go into membrane rupture and rip into that vessel. So these are all the implication of missing this diagnosis. So, and finally, let's see. This is another clip. I have had a patient that was sent in as a vasa previa evaluation. The reason I'm showing here is to kind of really get used to understanding the maternal venous congestion. How does it look like? And here are the maternal veins. Like I'm sorry, internal os is right here, and that's a maternal vein, and it's sitting under the membrane and it's flowing into the maternal stroma. That's the key. It flows into the maternal stroma. Another thing is, if you ask the mom to do Valsalva, it actually the blood flow decreases. Then finally, why 5 centimeter? We actually wrote an editorial recently, and because there are some anecdotal case reports of patients had lost the babies with 5 centimeter from the internal os. It's a point of discussion with the patients. You may not speak about it, but I'm going to bring up a vasa previa, and if talk about a distance, they're going to go to look up online. There are multiple social groups on vasa previa, and these patients are extremely passionate about the cause around this. So they will know more often than not, sometimes when they come back, more information on this. So it's going to have to be aware of it, about the distance, what it means, and how they're going to approach that for the pregnancy management. So once the diagnosis, then what? We compiled all the data that is there, and I put it into this slide. So you suspect the diagnosis, it confirm at 28, 32 weeks, and the hospitalization it's kind of variable from place to place. We do not hospitalize until 32 weeks. I personally recommend admission to the hospital 32 weeks, as long as the service is good. But when I was trained in Connecticut, we would admit them at 24 weeks. So it's variable from place to place, but I think more and more people are moving towards admission later in the pregnancy and monitor the cervical length along the way. The delivery is also variable from 31 to 37 weeks. Again, 34 to 35 weeks seems to be the sweet spot. The likelihood of needing an emergency delivery goes up as you go further into 34, 36 weeks, because more often than not, vasa previa also has a low-lying placenta that can bleed or spot. So urgent C-section delivery in a vasa previa, even if in the hospital, is around 15 to 20%. And it more often because of bleeding, pre-prom and preterm birth. I'm sure many of you have had enough experience on this. You have vasa previa in the floor, and she ruptures membranes, and everybody's dropping everything, running to the ward. So, we all had that experience. So that those things can happen about 15, 20% of the time. Now, despite that, there is a perinatal mortality of up to 3% in these cases. Again, it's a old paper, but the recent papers show that it's actually closer to 0%. I think it all comes down to your local hospital facility, resources, and awareness of the team as what to manage, how to manage if they have rupture of membrane. Not to underestimate the stress and anxiety of impending rupture, not only for the patient, is also for the team around, but for patients, this is, we talk to them, even the subsequent pregnancy, they go through a PTSD. I remember a patient had, where I was trained, patients in the antepartum was the 7th floor, and the labor and delivery OR was the 2nd floor. So we had to go to the elevators, get the elevator, go down to the OR, and then consider whether to do surgery or not. So every time they went into labor, had a little bit of spotting, we would take a ride down to the 2nd floor, and if things are fine, we come back again. So a patient had 5 times during a pregnancy that ride in the middle of the night. So it's just stressful thing for all team, patient, and the team. So that comes down to laser for Vasa Previa. The concepts are pretty simple. Basically, there is a vessel that is exposed over the cervix, and we put a fetoscopy, and then you ablate on both sides. The instruments, the techniques are similar to what we do for laser for TTTS. The only difference is we do this much, much later. I'm going to go into that, and that creates some anatomical challenges to do this procedure. The other important thing, when you do a laser for TTTS, we are kind of cornered. If you don't do laser, babies are going to die. Whereas here, you're doing a laser to improve the outcome for the mom and the baby. But you have an option, which is don't do it, do a C-section before they go into labor. So that option is that kind of creates a mental gymnastic for the surgeon. That's another talk altogether. So in generally, what we talk to the patients is risks of this procedure are preterm birth, PPROM, emergent delivery while doing the procedure, vessel ruptures or something, or a heart rate goes down, you have to do an emergency delivery. You could fail, the procedure could fail. Means we do it, but it doesn't seal off, so we have to end up still back to same where we were. Maternal injury and infection, these are all the risks, but they're all, I'm going to go into actual numbers we have now, but this is what we talk about. And the benefits are they can deliver at term, outpatient management, they can deliver vaginally, and also reduce the risk of intrapartum bleeding. So here are some of the papers that were published before we started doing them, and cumulatively there were 20 patients. As you can see, the one who had done the most then was Ramin Schmid on 20 patients. 70% could deliver vaginally, and he was able to take this pregnancy up to 37 weeks. And then in the same, he had another paper that basically divided into earlier 10 series, but there are other single case reports. So we did a study here at UT Houston, which was basically with the scopes that we use for this need and HDE. And we were looking at reproducibility and safety of this procedure. Initially, we were very, very selective in terms of where we offered this singleton pregnancy, type 2 Vasa Previa. And then we do this procedure in 28 to 34 weeks, not in active labor, not PPROM. We also offered for patients who are at TTTS, undergoing laser for TTTS, also found to have a Vasa Previa. And we had those patients as well. So our procedure is they have a betamethasone the week before for a lung maturity, just in case they may have to deliver during procedure. And we typically schedule it between 30 to 32 weeks. And on the day of surgery, in the operating room, we put them in the lithotomy position so they have easy access to the cervix and look at the vessel. IV sedation, we have done a few under general anesthesia, one on general anesthesia and spinal anesthesia. We usually have 2 sonographers, one for transvaginal, one for transabdominal. Usually only a single machine. We don't do double machine. We just have to switch back and forth with the probe. And we do have an assistant to help with the scopes and apnea infusion to improve the visualization. The way we do ablation is we identify the vessel, sometimes using combination of ultrasound and scope, and then we trace the vessel to the cotyledon, where it is rising or draining or supplying to the cotyledon. Then you ablate on the placenta as possible so that we can shut down the flow on the placenta. And when we do that, we note the complete cessation of blood flow. It's very important that when we do that, the blood flow stops. We don't let the flow going on and go to the other side because we don't want to leave any blind end on one side. And once that is done, then we go towards the proximal end, towards the cord insertion on the placenta, and then ablate so that we are neutral on both sides. So we confirm that These are the step-by-step approaches. And here is our schematic of how the operating room looks like when we do this procedure. And here is just to show you one of the clips from a patient. Now, that's the vision that we get, sometimes worse than this, when we're doing this procedure. We threw it through a little tunnel, and that's one of the vessels that we are ablating. That looks a smaller one, and that is a boomerang vessel of a Vasa Previa. Sometimes you can see the laser is just eclipsing on the vessel because this vessel is so big. Sometimes we go through this very delicate, little by little. We don't go hard at it because we don't want it to rupture. And we slow down the flow, then shut it down completely. And we confirm during the procedure that it's shut down. And here is an example of a patient that had a Vasa Previa over the cervix before surgery. And after surgery, you can see that vessel is basically has no flow and is thrombosed. In fact, we have a same team that does the ultrasound before surgery in the operating room and then evaluate the patient the next day or subsequently, because it's very hard to look for the vessel that is not flowing. And we know exactly where it is, and we bring down the flow when you're doing the ultrasound to make sure even if there's a slight flow through that, we pick it up. So in the initial series of 13 patients we screened, 5 were not a candidate because they were type 1, and then there was a maternal venous flow. And then among the 7 that were eligible, 1 failed. We could not completely successfully do that. I'll talk about that in the next slide. And then 6 of them we were able to successfully do the laser on. No, this is the first initial series just to give you an idea. Patients are, the red is the way they diagnosed to the time when they had a surgery. And many of them were diagnosed Vasa Previa. We kind of followed them, waited till 32 weeks, except for this one where a spotting and a short cervix. So we ended up doing it 29 weeks. And we were able to successfully do the laser on these patients. And the green is when they were able to go home and spend time at home and then deliver at the end. Except for 1 patient, we diagnosed them actually at 34 weeks. And the baby also had a Down syndrome. And she wanted to do a laser, and we attempted the laser. That was the latest I've attempted to do a laser, and that we failed. And I'm going to show why we failed on that patient. Because here is that patient that we failed. We had a good visualization of the vessel, doing a laser. I thought I was confident I got an entire vessel on the placenta that we ablated completely. The blood flow went from 6 centimeter down to 2.5 centimeter, but it kept flowing through the vein. I was not confident that I got everything. So we called it off and did a C-section. After the C-section, we look at the placenta. Here is where we ablated it. And you can see a little tributary right there that was flowing into the vessel. And that's the internal os and kept flowing. So we thought that's how easy it is to miss a vessel if you don't see it well. And then the mom and baby doing fine, but that's what the reason for the failure for this patient. Then we also had 2 patients that had a Vasa Previa with the TTTS. We did a laser of 1 patient successfully, no problem, delivered 34 weeks, but the other patient we abandoned to do the laser. I'm going to show you, it'll stick in your mind because I never seen a patient like this before. That was this complex placentation. So this is the laser for TTTS. You can see a recipient cord here, donor cord here, and the donor vessels travel all the way across the placenta to this placental territory on the other side. So usually when we see an equatorial plate, it goes like line across the 2 sides, but this one was a C-shaped, goes from here across all the way to the other side. And when we were doing a laser and I saw these Vasa Previa, when we traced them up and down, we knew that these vessels are the most important vessel for the donor. If I took it out, the donor would die. So we made a decision not to proceed. We called it off, and then she ended up delivering at 32 weeks. Now both babies are happy and doing very well. So it can be that easy to make a mistake of not knowing where the anatomy of the vessels are. So with that in our experience, we ended up doing more patients. Finally, in joining hands with other centers that run the most number of cases, USC, we were able to put a case series comparison, and Dr. Backley, as his fellows project, he was able to look at our own data that we did expected management of type 2, type 3 Vasa Previa, and he compared them side by side. This is the first time ever done. The paper is almost able to come out in the White Journal. You can see that expectant management and laser surgery, sort of comparable groups, the type 2, type 3. And then the kind of vessels they were, arteries and vein are both. It can be both in the same patient, a number of vessels and distance from the internal os from the both groups. And after the laser surgery, admission to the hospital was further along after the procedure is done, 36 weeks versus 32 weeks. And then also the rates were lower if they had a laser surgery. These were admitted because of P-prom or so on. The number of days in the hospital for the mother decreased significantly with the laser surgery. And also what was surprising to us that with the laser surgery, they delivered 2 weeks further along or 1.5 weeks further along than were to be expectant management. This is UT Houston experience of expectant management. They deliver an average of 34 weeks. Vaginal delivery, 63% deliver vaginally versus 0 in the expectant group. And the blood loss, of course, was higher in the expectant group because of the C-section delivery. And as you can see here, gestational delivery is much further along with the laser treatment. And I do have a data on the neonatal outcome. Again, the paper is not out yet. It makes a big difference on the NICU days, as well as the RDS and infection and transfusion neonatally is much lower with laser surgery. So seems to have a benefit for the mom and the baby with the laser surgery, but in a very selective patients. So bottom line, laser surgery for type 2 Vasa, type 2, type 3 is feasible and reproducible, and careful case selection is important. And the intraoperative transvaginal ultrasound confirm the cessation of blood flow is important and paramount, and reevaluate the vessels the next day and 1 week after. After that, we tell them to no pelvic rest, they can go back to normal activity and deliver vaginally. So we are working towards the registry nationwide, and also thinking about even doing whether a randomized trial or a kind of a trial that would help us elevate the science behind doing this procedure in these patients. So like to thank my collaborators and our team here at UT Houston, and also Sammy Backley to put all the hard work behind the data. And then Dr. Schmid from USC, who worked with us to put the data together. I'll stop